grand rounds. This is our return to normalcy after what has been a very challenging, but I think a very rewarding couple of weeks where we've really seen the true grit and resiliency of our department. I know our chair will have a few words about that in a second. And we have the honor of having Amanda McNamara, our Associate Director for Research Operations in the Department of Internal Medicine, who has been with us for a couple of years after we brought her back from Pittsburgh. Amanda was originally here in USF in pulmonary in our Department of Internal Medicine before she ventured up north, and we brought her back into the fold. Her topic is going to be internal medicine research operations, and I'm going to turn it over to Mark Mosley, our chairman, to talk a few words about his vision for research and the importance of today's grand rounds. Mark, take it away.
Thanks, Joe. I want to echo what Joe said. Thank you all for being here. It's a sign of your resilience as well as sort of the triumphant spirit that we have here at USF related to adversity. As the dean has often cited, we embrace stoicism and the obstacle is the way, and we've just come through a very difficult obstacle, and I'm sensitive to that. But what better way to come back than to grand rounds and really the heart and soul of the academic department. I want to again thank Joe, and I really want to thank Amanda. Really looking forward to this presentation today. I'll keep my comments brief. Our goal as a department is to be excellent in all mission areas. That is challenging. It's a high bar, and it's particularly challenging related to research, scholarship, and extramural funding. That's particularly challenging, yet again, in an academic, clinically focused department in a medical school. But we have to be able to juggle with more than one ball. And our goal is, of course, not to drop those balls in the process. I believe that we have greatness in pockets in our department related to research. And our goal over the coming years is to liberate that excellence on a larger scale. I don't know if you all can hear me. I'm sorry. Somehow my video cut out, but I want to say thank you all for being here. And I appreciate the opportunity for us to talk about this mission, to have some level setting around our current performance and areas and opportunities for improvement, and look forward to Amanda and her subject matter expertise here. And we'll be talking a lot in the department moving forward. Thank you.
Thank you, Mark. Amanda, take it away.
Looks like Amanda was kicked off. Let's give it just a moment and we'll see if we can get her back on.
We appear to be having some Wi-Fi
It must be the location.
Yeah, thanks for the patience. If this has been true grit and resiliency, I don't know what is. So, and of course, the first grand rounds coming back after Hurricane Milton wouldn't be anything other than this that we would expect. But yeah, thank you everybody for your patience. We'll get Amanda back on here in a second. We had for everybody to know, we were speaking with Amanda for a good 10 minutes before this with no issues. So of course, this starts shortly after we start grand rounds. But again, thank you for everybody's patience as we get Amanda back on here. Jen is probably trying to find a way to restore.
I'm working on it in the back end.
Yeah, I bet. That's it. She's trying to be the Wi-Fi restorer. Luckily, Amanda's presentation is right around 45 to 50 minutes to allow some discussion time. So all the material should be very well contained in this talk.
Message in chat says the SDC is out of Wi-Fi. I don't know if that's where Dr. Mosley and Amanda are right now.
Gotcha. Another option could be to take it by phone. Jen, if she just, has a decent data plan, which I'm sure she does, she can, just forward it to her email and then she could take it by phone.
Sure.
And then you would be able to run her slides, correct?
Yes.
So that's what I suggest, is that she calls in by phone, turns on, the camera, and then that you're able to run or keep the camera off to preserve the phone, depending on what she's got. And then you run the slides. There she is. So
we are having some internet connectivity issues here. Apologies.
no problem, Amanda. My thoughts were as backup, maybe to go, if you have any kind of bars, to go to the phone, and then we'll run the slides if this happens again. We can try to run through this, but that'll be our backup plan for you to go to phone, and then Jen will run your slides if that happens.
Understood. Thank you.
Thank you.
As I was joking with Dr. Mosley, this is a little bit of that resilience he's talking about, a little lesson here for all of us.
I mentioned that what would we, and I also mentioned that we were talking for 10 minutes before this all started with 0 issues. So it's not like we all pop on at noon. But what would we expect after Hurricane Milton but this? But Amanda, go ahead and run your presentation. Thank you so much.
Well, thank you all for joining us today for the Grand Rounds for Internal Medicine Research Operations. I've heard from many of you about your excitement about this presentation, and I do think that Hurricane Helene and Milton hyped me up a little bit more than I probably needed to be. With the additional cancellation and promotion of this, I think we may have had additional attendance. So thank you all for taking time out of your day to learn about what we're doing here. A few objectives that I hope you all will take away from this talk is to understand the internal medicine research infrastructure that we do have that is a resource to many of you. A lot of times you don't have access to something if you don't know what there is. So this is our goal to do that for you all. I hope that you'll be able to understand the clinical trial intake workflow and study startup that is a point of concern or interest for many of our faculty members. And I hope that you can identify many of our OCR contacts and partners that we work with every single day to get the clinical research done for you all. And we will also talk about research initiative accounts, facilities and administration, rollover funding, a lot of the financial questions many of you have. We'll do a high-level overview of that here today. A little bit about myself. Thanks, Dr. Lizama, for the warm welcome. Many of you who don't know me might wonder why I'm talking to you about research, why I'm here, and what my background is in. I graduated from the University of Iowa with a degree in health and human physiology and a minor in human relations. My first employment after that was really right here at USF. I started out as an LPN in the Department of Urology there for 4+ years before I made the jump to internal medicine, where I currently am as well. I served the lead role there, overseeing some of their clinical operations, and spent a lot of time with the patients, getting to know many of the faculty that still remain here. When they developed the Center for Advanced Lung Disease, they moved the pulmonary hypertension patients to TGH, and I was looking for more opportunity to connect with those patients, and a research opportunity presented itself at Tampa General Hospital. So I took my first research position there in 2018 as a clinical research coordinator. From there, I went to the University of Pittsburgh, and I served many roles as an implementation specialist for research in the Department of Critical Care. I was also a project manager and eventually became the assistant director of our clinical research core there and did similar to what I do now, just within that department. And then Pittsburgh was great, but there's no place like home is what I like to say about Tampa. And with many of familiar places and faces, really wanted to come back here to USF. And so this opportunity presented itself, and I was thankful to have the chance to come back. As like with most leaders, I really like to start with some good news. As we were talking before, many of you jumped on. I did present last year in 2023, and I wanted to start with a fiscal year 24 in review. Start with some good news. I have a few kudos to give out, but fiscal year 24 was pretty good to us. We had an increase in revenue of just over 12%. Many of our divisions did really well, and I wanted to highlight that here. Areas of impact that helped us with that increase in revenue. One of the areas that I'd like to highlight is our digestive disease research. There was an increase of revenue, 154,000 there, but it was an area that was mainly dormant prior to the last year with an increase in research revenue of 166%. And I want to share some of the actions that we made there to try and help this area along. The department invested and recruited in a team dedicated to this area, specifically knowing the opportunity that the IBD Center would have for research. So the team was developed, and we have a manager that leads them now. Her name is Dara, and we've affectionately call them the North Clinical Research Team. They are here on campus every single day, but they have been able to invest their time and effort into projects who have been dormant in the past to increase recruitment there, and then they've increased their pipeline trials as well. And there's so really excited there. They have 18 clinical trials in the pipeline this year. I would call them our fastest growing clinical research division, probably going to be very competitive in the next year with our other divisions as well. Our pulmonary research area, if you've been around internal medicine for very long, it's no surprise to you that they are the most productive. This is the second year in a row they remain the highest revenue generating division. What did we do in this area? Well, we've had great support from our TGH core team to help coordinate those studies. We did make a few adjustments internally to additionally support this area. We did recruit and onboard a dedicated team who we call the South Clinical Research Team. They don't only support pulmonary, but they do support the faculty for those USF studies here. We help support the transition of general pulmonary clinical research trials back to the department. And we also initiated a critical care research program, and we opened 2 trials within the last year. And one of those studies is tied for highest enrollment globally. Really excited about the critical care research program. That happens to be where my research background is in, so I do have a special passion for that. But we've developed really great relationships with our ICUs, with the closed bed situation that is new this past year has really helped us be productive in that research space. Other divisions have considered using this South Clinical Research Team because of their productivity, and I think that should be highlighted as a success for last year. The last area of impact I would like to highlight is our study startup operations. We'll get into a lot of study startup details later. You hear great things, and you may hear areas of opportunity there, but I would like to highlight globally that there was 39 trials opened in 12 months. So that's greater than 3 clinical trials a month, which is pretty successful and helps us bring in the trials to offer our patients. It's not the only way to be productive in research. I know we focus a lot on study startup, but it's also important for us to do recruitments after the fact. What we did in the study startup area is developed a centralized study startup process and invested in a study startup coordinator. That's Gabriel Parker. If you have any studies in startup, I'm certain that you have heard from him. He works very diligently in partnership with all of our Office of Clinical Research teams to get those studies open for you. Additionally, we've decreased our study startup submission timelines. I took out all the acronyms specific to each form that many of you may not know, but our USF submission time and our TGH submission time decreased from around 90 days prior to the investment of this role to about 16 and 13 days each, which is a pretty monumental turnaround time for the amount of work he puts in. Additionally, we had a lot of success with being site selected by sponsors to participate in trials. We had 2 really productive months, October and April. We put a lot of pressure on our friends in OCR because we were site selected for greater than 10 clinical trials each of those months, putting it into their queue. We did a little bit of restructuring as well. That happens, and sometimes it helps us be more efficient, and I think that was the case in the clinical research space. We optimized efficiency by creating the North Clinical Research Team that resides here on campus where I am now. They have direct access to Morsani just across the street. And then the South Clinical Research Team that is stationed at STC down on Davis Island that has access to the clinics and TGH inpatient units. The North and the South teams both support smaller portfolios, so they support more than one division. That's why they're not termed with the division name specifically. Should any of those divisions grow to be large enough to support their own team, we can separate that out. Right now, those divisions are separated due to geographical location to make it the most efficient for the team. Our current infrastructure looks like this. I love a good org chart. I've made updates to include our new chairman here. And this is a general overview of all of the teams within our department. You'll see a dotted line over there to emergency medicine. As we had it, I joke around a lot about an amicable divorce between emergency medicine and internal medicine because they're now their own department. We're so excited for them. We do still support them partially with their research endeavors. We have our central services team, which currently houses our clinical research operations manager, which was a new addition this past year, who helps us with our fiscal and business needs, running reports, payroll, managing our fiscal accounts, invoicing, pay distributions, you name it. Her name is Donna, and I don't think she's on today, but she's going to be a great resource to all of us. And then Gabriel Parker, our study startup specialist, also is in the central services group. We also have teams in allergy over at our clinical research unit off of Bruce B. Downs. Cardiology is located at the South Tampa Center. Our North Clinical Research Team, which I had mentioned there, South Clinical Research Team as well. And then we have an infectious disease clinical research team I have listed here. And we have an infectious disease research administrative team, which has multiple teams underneath it, and that's led by Brent Forget. There are all of the positions in black are currently filled. The positions in red are either currently posted for filling or currently in consideration for filling in this fiscal year. As you can see, there is a lot of resources within our department. If you do reach out to me, I can do my best to contact you with the most appropriate resource. Our current research portfolio, I just looked yesterday. It's a round number at 100. I don't think I could have made that up if I tried. And we have 95 studies in the pipeline. So if all of those come to fruition, we're on pace to double our research portfolio, which is really exciting for all of us that work here every day. I'd like to break it down by division so you can see the comparison. The dark green here is the open and active clinical trials. Maybe not all of them are necessarily recruiting still, but it compares it to their pipeline trials. And as you can see here, pulmonary has the most open and active clinical research trials. Cardiology has the most in the pipeline, but a lot of areas have a lot of exciting research coming their way. As you can see, we're working almost just as hard to open trials as we are to recruit patients. The studies in the pipeline, Gabe did such a great job in helping me break this down a little bit further because there are different phases of study startup. So we broke that down a little bit for everyone here. Out of the 95 that are in startup, you can see by division here which ones are in pre-site selection. And I'm going to go through the study startup process for everyone, so you'll be able to see what that means in a little bit. The studies and intake, which is active study startup being processed. And then we do have a paused column. Sometimes they're paused by sponsor or other reasons, but it's all listed there for you. And to add a little color, you can see a pie chart that cardiology definitely has the highest level of incoming trials, which is really exciting. The department does offer centralized resources to investigators, and I wanted to highlight those here for everyone so you know what we can assist with. If you have investigator-initiated trials, often if you're going out for funding, you would need assistance with the budgeting or what our costs might be here at the institution. We can help you with I hate writing words that I cannot say today. I need another cup of coffee, I think. Helping you operationalize them. So I've had many investigators come to me and want to submit for a grant, extramural funding. And if it's with, a pharma company or something like that, it's really important that we make sure that the costs are covered when possible. And with our partnerships with OCR, we can help you with that. I also have a global view of processes and resources in alternative other locations, so we can help see whether there is support in a different area that you might not be aware of. We can also connect folks with clinical research mentorship to junior or to help mentor more junior faculty members. We also support clinical trial fiscal review. It's really important that we look at these clinical trial budgets early. A lot of projects do have an appropriate budget to support the research, but sometimes we get requests from smaller companies and we need to figure out what's our tolerance level for providing support to these companies for less than what the cost would be. We have those conversations. Some of you on here may know if we've had those in the past, you would remember it because it usually has to do with me telling you, hey, this is a pretty low budget. It looks great to you. And then I kind of go through the costs with you. Don't ever take that personally. I do that in every division. We always hope to make it work. So that is support that we offer. We also do the centralized hiring for research. It helps with hyper-resource utilization. If there's resources in another area that are underutilized, maybe we don't need to hire and we can offer you support sooner than going through the hiring process here at USF. It's also nice to absorb that administrative burden. We all know putting through the HR paperwork is cumbersome, and it's nice to have support to do that. I have leaders on my team that help me. I help other divisions do it as well. So if you need that for research specific needs, please let me know. And then if you need any assessment of your budgetary review to see if you can support a staff member or not, we can also assist with that. OCR alignment, that's our Office of Clinical Research. If you may not be aware, this is something that Gabe does really well in study startup. He partners with every single one of their teams, from regulatory to budgets and intake to our technology transfer office, meets with them frequently to move all of your studies through. So we are constantly in partnership with them, which is a huge asset to our department and our research operations. Briefly touched on fiscal assistance in the past, but I've worked with divisions within this past year, reviewing their funding available to support staff, gave them feedback on optimization and how to utilize it most effectively, and made a plan for the future. We can do that too. Donna, our operations manager, assists with, and some of Brent's team also assists with pay distributions. They make real-time changes every pay period to make sure that payroll is done and on appropriate accounts. Contract support, depending on the type of contract, we are able to assist with that and connect you with the most appropriate folks within the department to assist with that. And then, of course, study startup assistance. And then me, I'm happy to be a resource for anything that you need. And now I'd like to talk a little bit about study startup process, which happens to be a really big focus of ours. And I used this meme last year, and I would love to say it's not necessary to laugh at this year, but it totally is. If you're not done clinical research before, an SIV is a site initiation visit and is the very last step before you can begin recruiting patients. And almost everyone comes to us and asks, can we have an SIV yet? And they may ask as many times as these children in the back. And I don't mean that to be a great analogy, but it made me laugh because I'm sure that all of our OCR partners here and Gabe and I feel like those in the front of the car saying, if you ask one more time, we're turning it around. We really don't feel that way, but I'm going to go through a high level explaining to you all of the steps that we have to go through before that can happen and all of the hands that it has to go through. We're supported by many people. All new clinical research trials for USF staff or USF faculty must come through the department. If your contract is held with USF, we must run this through the department, and two, USF OCR. All you have to do to kick that off is forward that clinical trial opportunity with your interest and commitment to Gabe and me. We have a joint inbox here, but we have been reluctant to use it to its capacity. If you send it to me or him, we'll make sure we get it going for you. If you're able to include any planned sub-investigators to support you, that would be really helpful at that time. And then I say we here, we take care of the rest, but really it's him and the OCR team that do that. His role plays a major impact on the efficiency of getting these trials started. He's really tasked with tracking all new studies coming into our department in a centralized location. He initiates the correspondence with all the external stakeholders and the internal stakeholders. Even if there is a study team in your division, he still serves as that central point of contact, as that project management role, if you will. He assists with protocol review, completes all of our internal forms that are required, all of the forms by the sponsor. He maintains consistent communication with internal and external stakeholders. And what he really needs from you to make that as productive as possible as faculty really is to be responsive. One thing you'll hear me say throughout is that we cannot do the research here without you or your participation. So if he's reaching out to you via email, if he's reaching out to you on the phone or trying to set something up with you, it's more than likely that we need that confirmation or that answer from you to move that next piece forward. So, and we will find you to try and check in on you, even if it means walking to you in clinic or the cath lab, but somebody will. This has been really helpful because it creates a strong central line of communication for sponsors, and it's really helped us get studies moving quicker. This is a terrible picture of a really massive spreadsheet that he keeps. Our study startup tracker is massive. If you want updates on where your study is in that pipeline, Gabe's going to be your person. He will have the most up-to-date information. It's really important for us to communicate with the faculty. When does study startup start? When we're talking about thoughts of a delayed study startup timeline or feeling like it takes a long time, it does take a long time. It's a very complex process, but it may not always start at the time you first hear about it, and it in fact does not. So I want to communicate that studies do not actually start up until we get to the bottom of this flow chart. So first we have to have your interest. We have to complete a confidentiality agreement with the sponsor if it's required. Typically it is. That goes through legal to make sure that you're not signing anything on behalf of the university that you shouldn't. Once that's completed, The sponsor will send us a feasibility questionnaire. Gabe will work through that with you and study team. That gets back to the sponsor. And then they will set up something called a site qualification visit to interview us to see if we are a good fit. Study startup still has not started, and this might be a few months in the process, depending on whether the sponsor is ready to take on sites or not. After that, if they decide we're a good fit, we're at site selection. Once site selection happens, often we receive a packet of documents. Depending on where they are in the study startup or study phase of their project, this may not be received right away. They may not be ready yet. If we're at the end of this study, they may already have these. So when we receive these 4 documents, that's when we can consider study startup beginning. At a minimum, we need a draft budget, a draft clinical trial agreement, the contract. We need an FDA approved protocol for FDA regulated trials. That is key. And an IRB approved, oh, I put protocol there. It's supposed to be an informed consent. So FDA approved protocol and IRB approved informed consent. Those are required because the protocol and informed consent have impact on the budget and the contract. All of those are necessary for us to review and for you to decide that you want to participate. If you agree to the trial, that's when study intake begins. So it may be a few months when you've heard about the study to when intake begins. And if you don't want to do the trial, obviously we'd stop there. After that, we do an internal feasibility review with the department, and then the startup operations from there differ slightly between whether or not it's a USF only study, or if any piece of that clinical trial touches Tampa General, there's additional components to get their approval. I'm not going to go through every single step on this flow chart here, but this is an overview of after site selection of a USF only trial. So after we've gone through the other process, all 4 of these processes can begin in parallel. The study team completes their internal feasibility, and then they also complete internal study startup documents. The regulatory team, if we're using Luis Diaz's team, would start their ICF creation, working with the sponsor. That's a negotiation about the language of that. There's additional regulatory documents that they will complete. The budget team, they do an initial review, but they pause, as you see down here, that they're waiting on something else. And then the contract team also works to finalize their contract language. All of these teams begin in parallel, but at the end, we all end up waiting for the final budget negotiations with the sponsor. And this can be delayed because, as you can imagine, some sponsors don't want to pay what we're requesting. So after that back and forth, that would be put together after agreed upon and put into the clinical trial agreement there. Once the agreement is fully executed, that's when, as in the meme previously, that's when you can site initiation visit, if you will. After that, we still require a few approvals, and I'm going to go through all of the teams that this touches and impacts prior to startup. If you have a study that touches Tampa General, that needs a CT at Tampa General, an echo at Tampa General. If it's a cath lab study, an inpatient in the unit study, if you're recruiting from the ED, if you're recruiting from pretty much anything on Tampa General campus, if you use IDS, which is investigational drug services, which we often use their team, we have to go through a TGH submission. So all of the steps from the previous slide, plus the TGH intake steps here, and TGH is in blue, just to kind of separate those. But everyone always asks for a workflow, so I put this together to share with other people. We are supported by the OCR budget team at USF here, led by Melissa. We are such a robust department that we require 4 of their budget analysts to help us. So Josh, Brittany, Mark, Alima are really supportive of us And they are constantly negotiating on our behalf. One thing I'll say about their team is it is their goal to get our costs covered. So when they're negotiating with sponsor, we want them to play hardball a little bit. We want them to go out for what our institutional costs are, and we want them to get costs covered for coordinator time and effort. All of our coordinators are paid for from research dollars. So the money that's generated from clinical trial effort is how we pay our research team. And so when you may hear from a sponsor, hey, your team came out with a high budget, they can go back and negotiate with this team and they're able to help us do that. But just know that it is what we want them to do, to go out and advocate on our site's needs to run the trial here, especially for industry sponsored studies, because these companies have a lot of money and stand to make a lot of money from the work that we're doing on their behalf. So we just need to make sure that we're able to just pay the people to do the work on the project. The budgeting process is very complex. It starts with some internal documents. Gabe and study team do go through the protocol. They pull out every single thing in there that could drop a charge, be a cost, what's time and effort, does it need an x-ray, an echo, drug dispensation, room utilization. It is comprehensive. All of that is put together for the budget analyst to create a budget for our site and go out to sponsor. Once that is agreed upon, they hand it over to the contracts team, and then they go through a budget approval process. Our contracts team is also always working in the background. They're led by Yesenia. Also supported by Reagan, Christina, Emily. I think I'm missing a person on here. I think we had a new hire. Apologies if anyone from OCR is missing on this list. They go out really early to negotiate this contract language. They're fantastic at seeing if they can replicate from other agreements. I would call them like a shadow team. They're often out there working on our behalf without being in communication, but they really support us. So their team also touches it. Their process is when they receive the draft CTA, they review the language. They confirm a lot of the language that's in there about with us, the study team and the PI. Can we meet the requests of that sponsor? Some of the language that they ask us about are how quickly can we notify the sponsor of SAEs, FDA audits, confidentiality breaches. Just they make sure that we can meet the commitments that are within that agreement. They have USF legal review the language. There is a back and forth between sponsor and the legal team about the language that's in there. As of lately, the newest one from a state statute is the human trafficking language that has to go into every contract. So they're having to redo many of those for us. After they receive the sponsor feedback, they're able to finalize the language in the clinical trial agreement, but then they stop and wait for the budget team to have their completed negotiations, because that's the final piece that goes into the clinical trial agreement. We're also supported by a really robust regulatory team. Luis and team on the USF side, Christine, Amber, Mariana, and Yushra. We also have a TGH OCR team that supports the regulatory needs. Any study that has the funding to support their services, we enjoy utilizing them. They're fantastic and they're specialists in what they do. So really happy for their support. Their processes that they have to go through, there's a few different pathways that are an option. There is what we call a single IRB, which is where our local IRB would agree to cede review to an external IRB for a USF only study. The same process can be done for a TGH joint study. And then there is a local IRB only submission, which we don't do as many of those, but it's a separate process as well. And this is an overview of what those processes look like. There is a lot of regulatory paperwork that must be completed by their team. They have informed consent negotiations on language with the sponsor. Then they have to submit approval through our local IRB to seed review prior to submitting to that central IRB. This is a pretty in the weeds representation of their process. I won't go through every single item, but what I did do for anyone out there who wants to know more about regulatory processes or submissions, I have slides at the end that I can send anyone for submissions to local Bullseye IRB, which I have outlined here. We have an OCR intake team here at USF, and that's supported by Melody and Adam. They're the ones that our team will send it to when we are ready to move forward. We try to loop them in as early as possible, but you may hear from them as well, supporting the intake for OCR. The only team I have not touched on, I believe, so far is that if we do that submission to TGH and those additional reviews that I highlighted in blue earlier, those are supported by the feasibility team, and then the coverage analysis team. So similarly to how we do an internal feasibility here, there is an internal feasibility process at TGH, and I'll slightly go through that in the next slide. The separate forms we submit to Tampa General are called research support. Oh man, I'm gonna butcher this. Gabe, I'll have to call on you at the end to remind me. The RSPF, he submits that and it kicks off the feasibility process there. Their team, the feasibility team, really helps navigate us through the journey over there to help connect us with pharmacy, IT, TGH core coordination, imaging, any of the units. If you're recruiting out of an ICU, they're going to make sure that unit manager is aware and they're going to have sign off on the study. The Medicare coverage analysis team, this is a requirement to be done for all studies that touch TGH. This is support to outline all of the items in the protocol that are either billable to insurance or billable to the sponsor. And they really help us with billing compliance, which is a really important thing in clinical research. After these reviews are done, they meet with the study team to make sure that we're in agreement with everything that they have put in the Medicare coverage analysis, and they liaise between us and the unit managers to make sure that there is agreement on what support they will be providing, and then their sign off. If your study touches TGH, this piece must be done prior to the budget negotiations. After we get to that SAV part, all of these other steps have been done. We still cannot begin enrollment until we have TGH approval, which soon follows, and then USF approval and sponsor activation, and then we can begin recruitment. So that was probably the shortest overview that I could give, but I wanted to share just how complex that process is, because every study goes through all of those steps. All of those people listed there and probably more touch on your project. And every single one of those people is very committed to pushing those projects through. We work with them every single day. But I want you to keep that in mind when we're pushing your projects through, just all of the complexities you have to go through. It's really wanted to highlight here, study startup can be a really hot topic. It's very process driven. If you have questions on that process, I know myself or any one of our OCR leaders would be happy to explain to you why we have a process for that. I guarantee you there's probably a reason. And if we can skip steps, we will, but often we still have to go through each one of those. As I mentioned before, PI participation, faculty participation is necessary. Delayed responses, non-response, things may not move, if I'm honest. We will follow up with you, but if we don't hear back on something for billing, if we don't have your approval that is required, it will be delayed. So keep that in mind. I know everyone wants their studies started up as quickly as possible, but your participation is key. Study prioritization is really important to talk about, because everyone in internal medicine would love to have their study start up as fast as possible. Study prioritization is based on need, and it's also based on the amount of studies that we currently have. So if a study is truly prioritized, it's not only prioritized within the division, but then within the department, and then over all studies at the university. So when we ask for prioritization, we need to think about the reasons behind it. Is this study closing? Is it really important to get the patients this access to these treatment options? Is it truly more important than everyone in your own division, your colleagues' division, and at the university? Because teams outside of your own division, Gabe and I, for example, work to support all the other divisions. And then the teams at OCR work to support all of the university as well. And so just keep that in mind when we're talking about study prioritization. And we would love to prioritize them all, but we just want to be mindful of everyone else's research as well, because if we prioritize, there's an impact on others. Escalation of concerns, everyone's willing to receive feedback. Happy to do so. I think all of us are committed to a faster startup process. I just request that if there's a possibility to come internally to the department first, because it might be something that Gabe's already working on, might be something I'm already talking to leaders on. If you come to us first, we can help you, give you context to anything that might be going on that we're aware of, but also happy to partner with other leaders across our research at our institution. Now we'll talk a little bit about the money piece of things. This is I think a little less interesting depending on where you sit in the research ecosystem, but I get so many questions on F&A, overhead, indirect costs, facilities and administration. So I'm going to try and do a high-level overview of that. Essentially, F&A, indirect, overhead, they all mean the same thing. They stands for facilities and administrative costs. They're costs that are not directly related to a specific project. This is often added on top or of the project. It's built within the budget, we hope. And these funds are taken off to support other areas. And I'll break that down here in a second. What is the rate? This is often a percentage on top or an included percentage, and most of our sponsored trials are going to be the 34.5%. So think about 35 cents on every dollar that comes in is going to overhead for industry sponsored trials. And these are generated by the university here. These are not ones that we make up. But where does this money go? Often I get this question all of the time. So of the 35 cents for every dollar, 34.5 cents, 25% goes to research and innovation. This is the historical years. 25% has gone to the Office of Clinical Research, and then 50% is afforded back to the department and up to the department to split. The department has split these returns 50-50 with the PI since 2021. These returns are delayed at the end of every fiscal year and usually come about 7 to 8 months later. So those for fiscal year 24 have not been received yet. This is just a breakdown, an example. I will skip it because of lack of time. But of the 35%, this is how we would break down who gets the piece of each part of that pie. This is, I think, a duplicate. Sorry. F&A is slightly different for federally funded projects. The F&A is typically higher. It's typically around 49.5%. I think that other slide was supposed to say that. But the breakdown on the who gets which piece of that pie is different. For federal funding, Office of Research and Innovation assumes about 80%. The college gets 13%. The department gets 7%, and then that is split between the department and the PI. Another way to receive funding for the faculty members is something called fixed price residuals, also known as rollover funding. This is the amount of funding that's remaining at the end of your clinical trial after all has been paid and all of the overhead's been paid. This is what's remaining. I get something like this from the Office of Clinical Research Financial Management. They'll say this is how much is remaining after all of the expenses have been paid. Historically, we split this 50-50, and this half would go to the department and half goes to the PI into a research initiative account, which I'll go over in a second. Oh, next slide. So there are two ways for a PI to obtain a research initiative account, and I get RAA questions probably 3 times a week. The one way to get a research initiative account is for those annual overhead distributions. And then the other way is the fixed price residual funding, as we just went over. So there you can have 2 research initiative accounts, funding from 2 different mechanisms. But the questions I get and misconceptions are, does every PI have an account? The answer is no. But if you participate in clinical research long enough, you should. If you've participated in it long enough to have the F&A annually, you will have rollovers from that, or transitions from that. If you've had projects open and close that had residual funding, you should have residual funding from that put into your account. When we do roll the funding over to your account, you will be notified. I usually add you to that communication via email and say, for awareness, this money is being transitioned into your account. Most people want to know, how do I access these funds? How do I use them? How do I know how much is in them? You can email me, you can email Donna. Brenda Flam's great at this too, but I don't want to throw you out there, Brenda. We can tell you how much you have. Just let us know. We can pull the numbers pretty quickly. How do you access it? You can use it, but it depends on what you want to use it for. It's a state statute and what we can use state funding, state research money, research initiative money for. So the decisions related to whether you can use your funding for the request that you have has to do with a state statute. So when we make decisions surrounding that, that is not me deciding, it's not the department deciding, it's often related to what we are allowed to use the money for. Just a high level overview, you cannot purchase food, you cannot purchase drinks, we can't pay for celebrations from this money, but you can invest in research support, you can help pay research salaries, you can invest in research technology, equipment for your lab, for your coordinators. There's a lot of unique ways to utilize it. You can use it for research-related travel. The caveat is we just need a justifiable research reason. So I will write you back and ask you for that justification. It is because I don't want it to be an audit risk. I really want to make sure that we can confirm that this is for research and USF-specific research. Other PIs or other division chiefs cannot use another PI's research initiative account. The only person who has the authority would be the chairman. And I put chief, but I meant chairman. So Dr. Mosley is the only person who has the authority to override that. Why does the department tax these residuals? This helps us pay for administrative costs for research staff, study startup specialists. It helps pay for, the operations support for fiscal and business needs. It helps with startup support, seed funding, research sponsored events, cost share for faculty. We pay the clinical research bonuses for the faculty out of this. So, which I will go over here momentarily. This is something that will be coming out to faculty shortly. I've been working with Matt Anderson and others to determine the clinical research bonuses for faculty. This is also paid out of the residuals that we receive as a department. Many physicians ask, what's in it for me? Often you guys are all worked really hard already in academia. You know what? Sometimes there isn't an immediate gratification or satisfaction with doing it other than helping move medicine forward and helping your patients. But there is clinical research bonus potential for your participation. You must have a primary appointment in the College of Medicine. There is a long list of ways to qualify. I can send this out as well. But additionally, on top of this, it's just important to be a good citizen of research, make sure that you are doing the right things here on behalf of the department, and you meet these other qualifications. But those will be going out shortly. This is last year's that we paid from the department. As I mentioned this week, we just went through this week, so I didn't have time to put them in here. It's a similar amount though. It's close to 90,000 that the department supports to pay percentages back to the faculty for their time and effort on their projects. The same goes for NIH funding. The calculation here is quite a bit different. I will not pretend to understand the calculation or the economy factor, but Matt Anderson and team do this really well for us. So there's also incentives to participate in NIH funded research. And last year, this was the amount that was paid out to the faculty for their participation. So there are incentives to participate, they just might not be immediate. And then looking towards the future, what's next for us? I really would like to invest a lot of time and resources into reinvigorating our rheumatology portfolio, nephrology portfolio. I just talked to Dr. Shiroki, who is in my office, about how much I would love to have a research presence in general internal medicine here. Our goal is to hire and develop clinical research fiscal operations, whether we have that within our own reporting structure or under a fiscal director within the department. Those are in conversation now. We would like to provide additional fiscal transparency. And I just want to say that that's often limited by, we have 1.5 fiscal people for all of our research operations. It's just really challenging to get out the transparency that we're all hoping for, but we are working towards doing so. Also looking to try and continuing to discontinue participation in underfunded trials that don't support our time and effort. We'd like opportunities to host research workshops for new investigators. We'd like to add research orientation to faculty onboarding processes so they understand all of the resources that we have here and don't find out 2 years later that they have resources within the department they're not aware of. And then I'm really interested in onboarding unit research administrators to centrally support NIH research funding and grant submissions, grants management, because I think that our future research scientists and faculty are going to need that level of support here. And then I will open it up to the group. There may be questions or comments in here, but I really would like to hear from you in the last 2 to 4 minutes, and longer if you need. What do you hope to see from the department to support research this year?
Yeah, don't be shy. So please.
I was like, no comments are good. I can look at the.
No, please. I didn't see anything off the chat so far. But
Oh,
Dr.
thank you,
Sakari.
Yesenia. Good. I can look
Dr. Sakari? Okay.
at the.
Hey,
Sakari.
can you hear me well?
You're coming
Yes.
through
Yeah,
good.
thank you very much. I just want to say I'm new to this role in the Division of Rheumatology. I just want to relay my experience with you, and your team has been wonderful recently, helping me to transition some of the trials from Dr. Carter to me. It was amazing experience. Historically and blindly, I just always hear it's been difficult to work with research people and IRB people, but you guys have been wonderful. I just wanted to say that. Thank you.
Thank you. And shout out to you, Dr. Sakari. I mean, I chased him around a little bit and essentially begged him to take trials. So thank you for trusting me and coming along this journey with us. You heard me call out rheumatology, so you know we're really hoping to grow there.
I love it. I love it. Thank you.
Yeah. And thank you, Yesenia, for adding all the contracts people. I apologize to those that I have missed. I can update that. Your team has grown.
Yep, one of those brand new from yesterday.
Just quick question came to me, and I was in discussion with actually Dr. Lin from my division about that. With those research funds that they come eventually to the division level with the PI in the department, one of the ways to sponsor it, is it something you can use for research fellows? If they're going to be doing like an extra year of research fund fellows, if there's enough funds, or that's not allowed?
You know, you're not the only one who's asked that. Dr. Mohanty in cardiology has asked as well. Are you asking if research initiative accounts can be utilized to support a research fellow?
Yes, for a year of fellowship.
Yeah, I do believe that we can. When I was talking to him about it last week, I just wanted to confirm with our academic partners in the fellowship space just to make sure. But I do believe that as long as we're reinvesting it into research, we can make a case to do that.
Thank you.
Yeah.
Well,
Wow.
from the vice chair of education space. So, and I have national contacts that have worked on that before. So just keep me posted. As a great thought.
Yeah, I think there's a lot of opportunity there to provide support for fellowship from funding. I would just love to see it utilized to reinvest in research. So open to ideas there.
Absolutely. And I want to make sure, I know Dr. Mosley got cut off by the Wi-Fi monster at FOB. Just want to make sure if he's got his Wi-Fi, if he wanted to say any closing comments.
Great presentation, Amanda. Great way to kick us off around our critical research mission. Thank you for your leadership. Super excited about how we're moving forward. And thanks for your resilience as we dealt with the Wi-Fi. We're going to put a ticket in on that.
We're staying calm over here.
Absolutely. Well, it's 101. So if that's not efficiency, I don't know what is. So.
Well, thank you all. I'm going to put my email in the chat. Feel free to reach out if you have any questions. I am happy to talk to you directly.
Thank you. And Amanda.
Thanks so much, everybody. Take care.
Absolutely. Everybody take care. See you next week.